Hi, this is Jess Hoy, and I'm starting Pneumonia Chapter 2. Just for those of you who maybe took a little bit of break, just a quick familiarity, sharing the screen here. We just got done talking about classifications of pneumonia and hospital-acquired pneumonia and why hospital-acquired pneumonia and community-acquired pneumonia, what the importance is between between those two. So let us continue on to types of pneumonia. So there are a few different ones listed here. And just so that you're aware, viral pneumonia is the most common. It is mild to life-threatening. Usually when we have a viral pneumonia, up until 2020, we were talking about influenzas. Now when we have a viral pneumonia, a lot of times, once it becomes influenza season, influenza is still a part of the game. More often than not, in 2021, people have been hospitalized with a COVID-19 associated viral pneumonia. There are also bacterial pneumonias that people can develop, especially like, let's say somebody's got some sort of infection somewhere else in the body, and then that bacteria can travel through the bloodstream and set up camp in the lungs, creating a pneumonia. A mycoplasma, which is an atypical one, you don't see it very much. More often than not, what I've seen in practice is bacterial pneumonia, a viral pneumonia, especially in my COPD clients who have COPD as a chronic condition, and aspiration pneumonia. So aspiration pneumonia it's an abnormal entry of either oral or gastric material into that lower airway. So what happens is the swallowing reflex on these clients is not great, or for whatever reason, they have stuff in the gastric system. They have a little bit of regurgitation coming out up the esophagus, and instead of coming out the mouth, it actually just does a little U-turn and goes into the trachea. So major risk factors for aspiration pneumonia include decreased level of consciousness. We were constantly looking for aspiration pneumonia when I was on the ICU because we were sedating these clients who were on ET tubes. So a depressed cough or gag reflex, any sort of difficulty swallowing, and then any sort of insertion with nasogastric tubes with or without tube feeding. Our clients on the ICU had tube feedings to be able to keep proper nutrition going through their system, plus keep their gut material active and their gut working. So we were always on the lookout for that tube feeding coming up out of the GI system, and then, like I said, bypassing, because these people were sedated, it could actually follow right down their ET tube. So that aspirated material, whatever it is, triggers an inflammatory response. Primary bacterial infection is the most common, just so you're aware. And then there's aspiration of acid gastric contents will initially cause some chemical or non-infection like pneumonitis, and that can result in a possible bacterial infection within 24 to 72 hours. We will be, with people with aspiration pneumonia, doing some empiric therapy, more on that in the next chapter, based on probable causative organisms, severity of illness, and then any sort of client factors. Necrotizing pneumonia I have listed here, and that's a rare complication from a bacterial lung infection. It often results more from a community-acquired pneumonia than from a hospital-acquired one. And the signs and symptoms include immediate respiratory insufficiency or failure. Like necrotizing means the lungs are dying. So there's going to be leukopenia, there's going to be bleeding into the airways. For treatment, these people are going to be on long-term, heavy, big gun antibiotics. They could possibly have surgery to have some of the necrotized tissue removed, and with the hopes that we would also be removing any sort of potential for more lung tissue to get necrotized or to die. And then opportunistic pneumonias are most prevalent in immunocompromised patients, whether they are immunocompromised because of a lack of their own immune system or whether they are immunocompromised because of medications they're taking. People who have autoimmune disorders are medically immunocompromised so that they don't experience the symptoms of their autoimmune disorder. So immunocompromised patients may also have severe protein calorie malnutrition. They may have immunodeficiencies. Some of these opportunistic pneumonias take advantage of chemotherapy and radiation recipients, long-term corticosteroid therapies, and they can be caused by bacteria, viruses, microorganisms that don't normally cause problems. That's why they're opportunistic. They're just like, oh, everybody's away. The immune system is gone. So boom, here I am. And it will cause pneumonia. There are some other sorts of opportunistic pneumonia associated with like HIV, especially this pneumocystis jirovecii, which is a pneumonia commonly abbreviated PJP. It's a fungal infection, and like I said, it's commonly associated with HIV, and it has slow onset. It has very subtle symptoms, but it can lead to life-threatening respiratory failure. Those funguses can lead to other organs, and then the treatment involves sulfa drugs. This particular fungus does not respond at all to antifungals. And your clients who have HIV and when you're suspecting a fungal infection will have fever, tachycardia, tachypnea, dyspnea, non-productive cough, hypoxemia, and then their chest x-ray will show diffuse bilateral infiltrates to a massive consolidation, which means they have infiltrates throughout their chest x-ray, but then they'll also have an area of whiteout consolidation, massive consolidation. So basically these symptoms look a lot like other symptoms of pneumonia. We will discuss the pathophysiology, and then we'll still discuss the manifestations here in just a moment. So the pathophysiology is we're going to be having once the body is like, whoa, I see you, it starts an inflammatory response. And there is an attraction of neutrophils to that area. There's a release of inflammatory mediators, and then there's an accumulation of fibrinous exudates, red blood cells, and then that bacteria. So the alveoli are going to fill with debris and fluid. That's why it looks more white on chest x-rays. And then there's an increased production of mucus, which creates mucus plugs, which creates airway obstruction. But that mucus is there to be like, you are not allowed in here, and it's trying to protect the airway as best it can. Unfortunately, it creates problems along the way. These problems between the consolidation of those alveoli being filled with fluid and debris and the increased production of mucus create a decreased gas exchange. So carbon dioxide can't get out, oxygen can't get in. The resolution of the infection when things are going the right way is the macrophages in the alveoli will ingest and remove the debris. And then the normal lung tissue will be restored, and then gas exchange goes back to normal. So when everything is working right, this is what happens. So I'm going to stop here because I have had a big chunk of information, and I like little chapters, so you guys can only have to listen to about 10 minutes of me at a time. So I'm going to stop sharing, and then I will continue on, and we were going to start at assessment. So I'm going to stop, and I will see you for nursing assessment of these clients.